Hi there, folks. This is Chibi Medicine, and today we're talking about headaches. All right. Okay, so there are different kinds of headaches, and we'll talk about probably each of these furthermore as we go along with the video. But the first one would be your primary headaches. So if you're looking at separating them into major classes, those will be your primary headaches, and your secondary headaches. So your secondary headaches will be as a result of something else, usually something more serious. Then your primary headaches would be the quote unquote normal headaches, right? Even though they don't really feel normal at the time, right? So the first one would be migraines. Okay, this would be the ones that are episodic. They tend to be unilateral and have pulsating patterns of pain, right? So they're on one side of the head, and they're going to be just the way your heartbeat is going. That's the way you're going to feel it, that pulsating pain. All right. And they're usually associated with a prodrome and aura stage, which we'll talk about later, where you can get some nausea, some photophobia, and phonophobia, which is why some folks, when they have migraines, just like going into dark rooms, dark, quiet rooms. Right? Okay. The next one will be your tension headaches. So this should be your normal headaches, for lack of a better term, normal headaches. Right? They're usually bilateral and non-pulsating, and they cause like mild to moderate pain, so they're not terribly serious. Usually associated with either stress or muscle tension, or if you just lay wrong, you can get up with a headache, that sort of thing. Okay. Then you have your cluster headaches. They are severe, they're unilateral, but they happen around where the eye is. All right. So that's with cluster headaches, and they tend to form or have some other sort of symptoms like lacrimation, which is excessive tear production, right? Nasal congestion, and can also cause ptosis, which is like a lag in your eyelid. All right, but we'll talk about that in later slides. Okay, so for secondary headaches, they're usually as a result of head trauma, vascular disorders, specifically subarachnoid hemorrhage, infections like meningitis, and neoplasms. Okay. In terms of diagnosis, you're going to want to do some history taking to find out, well, what's the onset of it. Is it sudden? Is it gradual? The sudden stuff, as you can imagine, might be a bit more severe. You want to find out the duration of it and frequency. Right, so the duration in terms of how long does this particular episode of headache last, and also how often does it occur. That would be your frequency. Okay, where's the pain? Is it one-sided? Is it on both sides? And just what's the level of pain, like 1 to 10? How terrible is it? And do you have any other symptoms, just maybe not the aura stage of migraines, which we will talk about? Nausea, fever, or visual disturbances? Okay, on to the next. Now you want to check out or look out for certain red flags. Right? So if they have systemic symptoms like a fever or weight loss, so if it's like a fever, it could be meningitis. Right? If it's weight loss, it could be as a result of neoplasm. Right? You need to check for neurological signs. Why? Again, if you have a space occupying lesion like a tumor, you can, if it grows big enough, get some neurological signs. Is the onset sudden, like a thunderclap headache, which is what you can find in subarachnoid hemorrhage? Is the patient older? Because in older folks, they tend to have, or the risk of having something more serious is higher than in younger patients. Also, what's the progression of it? Is there a pattern to it, or is there a change in pattern to it? Okay. Now, on physical exam, that neurological assessment can be important, again, if it's not something like a tension headache that you can easily diagnose, or a migraine. The neurological assessment can be important to find out, perhaps where the lesion is, or if there's actually a lesion in terms of neoplasms. Right? Fundoscopy. So if, again, you have a space occupying lesion, or you have something like an intracranial increase in pressure, or an increase in intracranial pressure, you could find papilledema with fundoscopy. Right? Okay, now you can also do some scans like CT and MRI. CT is usually first, so non-contrast CT scans tend to be the first when you're trying to rule out something like subarachnoid hemorrhage, right? Or rule in either way. Lumbar puncture too can also be quite helpful when you're looking for something like meningitis or an increase in intracranial pressure, right? So if it's something like pseudotumor cerebri, so intracranial hypertension, that kind of thing, by even doing the lumbar puncture, you could make the situation better. And you can also diagnose in terms of meningitis if you do a lumbar puncture, because you can just send that to the lab and see what's in it. Now, you usually wouldn't wait to get the results back before starting empirical treatments in terms of meningitis, right? So your ceftriaxone and rifampin, even to the contact for the person. But yeah, moving on. Okay, let's talk about migraine. This usually has a prodrome, so an earlier stage where you're going to get mood changes, food cravings. Then it proceeds to an aura phase where you usually gets visual disturbances. So whether you can see flashing lights, or it looks like you're looking through broken glass, or you've got this scotoma where your field of vision tends to narrow a little. Then you've got the headache, which is, again, as we mentioned before, is unilateral. So it's on one side of the head. It's throbbing, so it's pulsating. There's a pulsating pain, and it can last from 4 to 72 hours. Okay. Treatment of it usually starts with NSAIDs. Right. Then you go to triptans and echo derivatives. You don't really use much, but yes, NSAIDs and triptans tend to be it. Now, you want to prevent getting such a serious headache, at least such a painful headache. So you can give a beta blocker, lepropranolol, or anticonvulsants like topiramate, but topiramate also has some side effects that you don't really see it being used too much in certain places. Okay. Then tension headaches. Tension headaches are like your normal kind of headache. Right? You have a stressful day, that's a tension headache. Right? Or you like slept wrong, or you, I don't know, just lay down wrong or sat wrong. Yeah, that kind of headache that comes. Yeah, that's a tension headache. So it's usually bilateral, pressing. And you've got that tight pain like at the back of your head and a band-like distribution. There is no nausea or photophobia associated with it. It's associated with stress, poor posture, or fatigue. I usually treat with acetaminophen, so that's paracetamol, right? And NSAIDs. Now you can prevent it by giving amitriptyline, or you do stress management or physical therapy. Now, amitriptyline is a TCA, okay? So TCA. And if you recall, TCAs also have quite a few side effects, right? So, and they have the action of being an antihistamine receptor or just anticholinergic side effects as well. So I wouldn't really see people giving amitriptyline much, but yeah, it's an option, right? Cluster headaches. So these are very severe pains, like not necessarily in terms of cause of it, but the pain itself is severe. It's a stabbing pain that usually happens around one eye, right? It causes stuff like tearing, so lacrimation, ptosis, drooping of the eyelid, right? And then nasal congestion. So it happens in clusters. So it can happen like every day for a couple of weeks, and then it's gone. Another thing to point out, and sometimes it's like a clue when you're taking an exam, like the step exams, usually occurs mostly in men, right? So there's one of those. In management, you also need to remember this: 100% oxygen, right? So just stick a mask on them. And so that's, again, because it's so unique, management is something that's likely to come up on exams. So yes, 100% oxygen is part of the management. Then sumatriptan, right? And then to prevent, you give verapamil, which is a calcium channel blocker. Okay. Secondary headaches, right? So you've got your subarachnoid hemorrhage, right? So on questions, you can see this as the worst headache of my life, sort of thing. It's very sudden, and like it's immediate, right? So it doesn't have that gradual thing to it. You can see some neck stiffness. Again, if you have a subarachnoid hemorrhage, that means you're bleeding basically into where you have CSF, and that's going to go all the way down. So imagine it to have some of the same or similar symptoms like you will have in meningitis, of course, minus the fever and other stuff, other systemic manifestations, right? So meningitis, you've got that headache with a fever, photophobia, and neck rigidity. Okay, and this is very serious. You need to start away on empirical treatment or empirical management of it. Temporal arteritis. This usually occurs in women above the age of 50. Right, by the way, it's also called giant cell arteritis. So giant cell arteritis. Okay. Now it's usually unilateral, and you have some scalp tenderness and jaw claudication, right? And also, you need to hurry up with this one as well. If you get a patient like this, now the diagnosis for it, definitive diagnosis for it, is biopsy. We're going to biopsy like several levels of the temporal artery. So if this is your artery, you're going to need to biopsy going down, like maybe biopsy there, biopsy there, just to make sure you get it. But even before you do all that, you need to give high dose corticosteroids. All right, so high dose corticosteroids. Now this is because part of that artery feeds the eye, right? So, or like a branch of it feeds the eye, the ophthalmic artery. Now, you don't want the patient to go blind, so that's why you're going to aggressively manage the patient with corticosteroids before going ahead to do the biopsy and verify whether you have that particular disease, so temporal arteritis. Brain tumors, the pain tends to be gradual onset. It happens in the morning, as the thing gets bigger, and you get some neurological deficits. Okay, again, if you have a space occupying lesion and it's pushing against, for instance, part of your frontal lobe, let's say, again, remember your motor cortex, your primary motor cortex, even in secondary, they're all in the frontal lobe, so you could find some neurological deficits in that way. Right? For the morning headaches, again, during the day you're standing up, so also the fluid is down the lower part of your body, quote unquote, of course it's circulating, right? But when you lie down, right, you now have gravity is not helping you, it's not helping your case, right? You now have a lot of pressure in the head, so that's why you wake up with morning headaches. All right, so that's about it, and join us for the next one. Thank you.